Hello everyone, myself Dr. Parth Goswami, and today I'm going to teach you about the severe acute malnutrition, that is a protein energy malnutrition formal name. So we will discuss the Kwashiorkor and Marasmus two types of protein energy malnutrition in the detail in today's lecture. We will see the pathological aspects as well as biochemical changes due to protein energy malnutrition in our body. So this is particular topic from environment and nutritional diseases from pathology section. So first of all, what is appropriate diet for us? So it means a sufficient energy should be there in the form of carbohydrates, fat and protein, which is our three main building block, right? So sufficient energy should be received in these three form for the body's basic metabolic needs, daily metabolic needs. The amino acid is utilized for protein synthesis and fatty acid used for lipid synthesis. And we know that vitamin and minerals serve as a coenzymes or hormone in the vital metabolic pathways. So that is the appropriate diet. Now, what is malnutrition? So, malnutrition is a consequences of either you have an inadequate intake of protein or calorie, either you could have a deficiency in the digestion, or all is good, then you have a problem in absorption. So that can also lead to malnutrition. So problem could be there at the inadequate intake, inadequate digestion, or inadequate absorption of the proteins from the gastrointestinal tract. You won't believe millions of people in the lower income nations are malnourished or they are living on the cruel edge of starvation. So it's a very big problem. So why it occur? Why there is a malnutrition? So if you think logically, then the common problem is poverty. If you don't have enough money to buy the foods, particularly in the homeless individual, aged individual, poor financial income, then poverty will puts you at a risk for malnutrition because you will take less food because of poverty. Acute and chronic illness, for example, tuberculosis and HIV, that will lead to tumor necrosis factor alpha. You have anorexia, and it will increase the metabolic need as well. So that could be the reason for malnutrition in chronic illness. Chronic alcoholism, the reason in a chronic alcoholism for the malnutrition is anorexia, poor diet, defective absorption, then abnormal utilization and storage, increased metabolic need, or increase rate of protein loss. So that could be the main causes for malnutrition in alcoholism. Ignorance and failure of diet supplementation is also one of the cause. For example, I am giving you the example, if there is iron deficiency in infant, then iron deficiency anemia can occur, and that can occur because exclusive artificial milk diet. If the infant is not getting enough breast milk and infant is on artificial milk diet only, then iron deficiency can occur. Police rise can give rise to thiamine deficiency. In certain regions where there is iodine deficiency, so it can put a patient at a risk for goiter formation. So that is one of the etiology. Another is self-imposed dietary restriction. For example, in starvation, due to any reason, if the patient is starving, self restricting the diet intake, then it can lead to malnutrition. Suppose you have a gastrointestinal disease, then malabsorption can occur, and particularly there are variety of malabsorption syndrome, like that of tropical sprue, celiac disease, like that of in which absorption in the body can affected, and so because of less absorption of the nutrients, you have a deficiency of that particular nutrients. So if we talk about the after etiology, if we talk about the pathogenesis of nutritional dietary deficiency diseases, then we can divide it at the nutshell into two types, primary or secondary. Primary means the lack of essential nutrients in the diet or decreased amount of essential nutrient in a diet. So intake is poor. That is primary deficiency. Now what is the secondary deficiency, also known as a conditional deficiency? So that occur because of variety of reason. Means intake is normal, but you might have problem in absorption, the utilization of nutrients. You increase excretion of protein in a urine, so that will lead to protein deficiency. Increased nutritional demand, particularly in a pregnancy, in a high metabolic state, the nutritional demand is increased. So if you don't increase your intake, then it can't suffice the daily need, right? So it can put you at a risk for malnutrition. Now, the World Health Organization has given the definition of severe acute malnutrition, that is the SAM. So the definition of it is that you know a weight to height ratio, that is 3 standard deviation below the normal range. For your normal reference range, if the height to weight ratio is 3 standard deviation below the normal range, then it is the severe acute malnutrition. And worldwide, 50 million children affected by SAM. So at the in the severe acute malnutrition, we have a two end of spectrum. The one is Kwashiorkor and another one is Marasmus. Now, before we understand the Kwashiorkor and Marasmus in detail, you need to understand that there are basically two protein compartments in our body. One is this somatic compartment, in which there is a protein in a skeletal muscle. So protein in skeletal muscles is known as a somatic compartment, and that is severely affected in marasmus individual. While the protein that is stored in visceral organ, particularly in a liver, that is known as a visceral protein compartment. So this is in a liver we have a visceral protein compartment, and that is more severely depleted in Kwashiorkor type of protein energy malnutrition. So now you can imagine that if somatic protein compartment is catabolized or if it is utilized, then your muscle mass is decreased and so you have a reduced circumference of midarm. Exactly opposite, if you have a problem in a visceral compartment, then the protein will be decreased because the liver is a main source for protein production. Example, albumin, transferrin, and others. So because of that, there is a hypoalbuminemia, decreased oncotic pressure, and patient will have a edema. So it is reflected by a edema. You can measure the serum protein as well for visceral protein compartment detection. It will decrease. So that is the main compartment, right? Now you can understand the clinical features of Kwashiorkor and Marasmus. Alteration in a microbe is also one of the hypotheses behind the development of severe energy malnutrition. So first let's talk about the marasmus. So in a marasmus, as we have discussed, somatic compartment is affected. So skeletal muscle protein is reduced, and that's because of lack in a calorie. Here there is a lacking in a dietary intake. You are taking less food, so overall calorie intake is less. And so obviously patient weight will falls to the 60% of the normal sex height and age. Imagine 60% weight reduction is there. So patient will have a weight reduction, loss of muscle mass, growth retardation as a result of catabolism and depletion of somatic protein compartment. So somatic protein compartment is affected. That's why muscle mass is reduced and arm circumference is reduced. Hair is very thin and dry because of lack of protein. And there is no edema. Edema is seen in Kwashiorkor, not here. So here the extremities are very emaciated because of the protein loss from somatic compartment. Head appears too large for the body. So that is the feature of marasmus. Now what is Kwashiorkor? You can see the edema, right? In a Kwashiorkor, the main problem is protein deprivation, not overall calorie intake. Here the main problem is protein deprivation. The name Kwashiorkor derived from the language Khana, language in a Khana. They describe this illness in a young children that appears after the arrival of another baby. So here the problem is less protein. So the problem, less protein in our body could be because of protein loss. For example, protein losing enteropathies, the nephrotic syndrome in which the protein is lost in a urine, excessive burns in which the protein is also lost in a urine and from surface, right? So excessive protein is lost in burn as well, or it could be because of chronic diarrheal state, right, in which the protein is not absorbed. So if you have a gastropathy, enteropathy, then protein is not absorbed, so that is also one of the cause. So because of less protein, oncotic pressure decrease and patient will complain of edema, patient have a edema. Fatty liver and loss of appetite is also present. So patient will have a edema because of hypoalbuminemia, and that's why there is a reduction in oncotic pressure. So that is the mechanism behind the edema development. And the protein is low because the visceral protein compartment is affected. So liver can't produce enough protein. Uh, you know, the weight of the children in severe Kwashiorkor typically is 60 to 80% of the normal. Means 60 to 80% having normal weight. So why is it so? The reason is that the loss of weight is masked by increased fluid retention. Patient is having edema, increased fluid collection. That's why the weight is falsely high. In fact, it is reduced, but here it doesn't come as a low because of fluid retention. Characteristic skin lesion develop in Kwashiorkor, that is the alternate zone of hyperpigmentation, desquamation of skin, hypopigmentation. So these three zones are there, that is known as a flaky paint appearance. Here you can see this is the hypopigmentation, this is the hyperpigmentation and desquamation of skin. So that is known as a flaky paint appearance because it's look like a flaky paint. The hair changes will also occur, particularly the patient is having alternate bands of pale and dark color zone in a hair of face, right? So in a hair there is alternate pale and darker bands. That is known as a flag sign. And the form attachment to the scalp is lost. So that's all about the pathogenesis, etiopathogenesis of Kwashiorkor and Marasmus. Now let's discuss the morphology in a Kwashiorkor and Marasmus. So if we talk about the morphology, then in the liver there is a fatty change, particularly in a Kwashiorkor. So here you can see a fatty chain. This is the microvesicle, then macrovesicle, and fatty cyst. In a macrovesicle and fatty cyst, the lipid will push the nucleus to the periphery. So fatty liver is seen. That is one of the common morphology. In a small bowel, if you take a biopsy, then there is a decreased mitosis in a crypt of gland, and there is a mucosal atrophy and loss of villi. Right? So mucosal atrophy is seen. Patient will have a growth failure, peripheral edema, and muscle atrophy and the loss of fat. So muscle atrophy is also there. If we take the bone marrow aspiration, then patient is having hypoplastic bone marrow, and patient will have a anemia. Particularly if nutritional deficiency of iron is there, then patient will have a microcytic hypochromic anemia. And if the patient lost the B12 folate, then patient will have a macrocytic megaloblastic anemia. In a brain, there is a cerebral atrophy, reduced number of neurons, and and impaired myelinization of white matter. So that is the brain pathology. Lymphoid atrophy and thymic atrophy also seen. So this is the marasmus in which the somatic compartment is lost, and this is the Kwashiorkor where patient is having edema. The muscle is look normal. Here there is a no reduction in a somatic compartment, right? In a Kwashiorkor, the main feature is edema. So that's the difference between the Kwashiorkor and marasmus. If we talk about the definition, then Kwashiorkor is because of protein deficiency mainly, and the calorie intake is sufficient. But in a marasmus, you have a lack of calorie, less calorie intake. So patient is starvating. So it's mainly seen in infant with starvation, overall lack of calorie. If we talk about the clinical feature, then in Kwashiorkor, you know, the patient is having mainly edema, while here edema is absent. Anemia and serum protein can be low in both condition. Here over the face, in a scalp hair, there is a flag sign. That is alternate zone of pigmented and depigmented hair. And here there is a monkey-like face in marasmus. If we talk about the morphology, then main morphology in the Kwashiorkor is fatty liver. And here there is a no fatty liver. Here there is atrophy of different tissues and organ, particularly subcutaneous fat is lost. So, what is starvation? That is the main cause of protein energy malnutrition. So, the starvation is a state of overall deprivation of nutrients. Means the patient is deliberately fasting. The reason could be religious, political, or anything else. If the patient is doing deliberate fasting that could not suffice the daily metabolic need, then protein energy malnutrition can occur. Famine condition, in particular, some countries the female is not giving is has not been given enough food as compared to male. That can also be the reason. Infection, inflammatory conditions, liver disease, and cancer that will also puts you at a risk for starvation and protein energy malnutrition. So that was all about the etiopathogenesis and morphology of protein energy malnutrition. Now, what metabolic changes will occur in our body in case of an starvation? So it's a gradual process. First of all, be clear that it's a gradual process. So there is a gradual decrease in the metabolic rate. And so the storage carbohydrate will be utilized first. The changes, biochemical changes occur at all three levels, glucose, protein, and fat. And starvated individual, particularly having the lax dry skin with wasted muscle and atrophy of internal organs. Muscle wasting is there. First, glucose. What biochemical changes occur in a glucose? So, normal body has a glucose store for up to 1 day only. And during fasting, the brain and renal medulla, they will continuously utilize the glucose because they are the insulin independent tissue. But the muscle do not utilize the glucose constantly. There is a release of glycogen from the liver by glycogenolysis. So because of glycogenolysis, the glucose is increased in a blood because the glycogen breakdown to glucose. Hepatic gluconeogenesis is aggravated. So no new glucose formation molecules will increased because of starvation. Now protein. So protein store and triglyceride of the adipose tissue have enough energy for the 3 months. See, the energy could be for the 3 months, right? So in a starvation, the protein breakdown releases the amino acid. We know that protein is made up of amino acid. So once the protein is breakdown, the amino acid is released and that will be utilized as a fuel for hepatic gluconeogenesis. So here, the gluconeogenesis is due to the utilization of amino acid instead of glucose, right? So use of protein for gluconeogenesis will produce a negative nitrogen balance. Now fat. So after 1 week of starvation, protein breakdown keep on decreasing and now the triglyceride in the adipose tissue will break down to form a glycerol and fatty acid. So after 1 week, the fat will utilize mainly and free fatty acid is released that can convert into ketone bodies. And we know that ketone body can be excreted in a urine and ketoacidosis can develop. So starvation then continue till all body fat exhausted until the body utilizes all body fat, the utilization will continue and ultimately death is the outcome if starvation is continued. If we talk about the laboratory finding, then serum glucose is decreased because of utilization of amino acid for glucose production, and ketone urea can be seen. So in a urine there is a ketone urea and increased urinary free fatty acid level. That's because the fat is broken down, so fatty acid will be released in a urine, and that fatty acid can convert it into ketone bodies. So ketone urea is also present. So these are my references for the today's lecture. So if we talk about the morphology, then main morphology in this particular is fatty liver, then villus atrophy, muscle atrophy, bone marrow is hypoplastic, microcytic hypochromic anemia, macrocytic anemia, brain cerebral atrophy, thymic and lymphoid atrophy. That is the main morphology. And the pathogenesis is different in Marasmus and Kwashiorkor. In a Marasmus, somatic compartment skeletal muscle protein is utilized, while in a Kwashiorkor, visceral protein, liver protein is utilized. That's why there is a emaciation, loss of muscle mass in a Marasmus and edema in the Kwashiorkor. Because in a Kwashiorkor, because of protein loss, because of protein deficiency, there is a reduction in the oncotic pressure, and that's why patient is having edema. So that's all about the today's short tutorial. I hope you have enjoyed this particular video. If you have any questions, then you can ask me in the comment section. Thank you very much. We will be right back with a new video. Till then, take care and bye bye. Thank you very much.